Welcome to the Masterclass Series. I'm Judy Dukeshire, the Director of Nursing in the Future, and I am so privileged to have an outstanding panel of nursing scholars from across our beautiful country. So let's get to it. I'd like to start by introducing our esteemed panel. Dr. Claire Mallette's career is diverse, with roles in academia, administration, research, and clinical practice in the provinces of Quebec, Alberta, and Ontario. Claire's been a leader in both practice and academia in such roles as the director of the School of Nursing at York University, director of education at the University Health Network, and the chief nursing officer at the Workplace Safety and Insurance Board in Ontario. She is presently the director of the School of Nursing and an associate professor at York University. Her areas of research and interest are in fostering quality, compassionate care, leadership, and positive work environments within an advancing technological healthcare system. Claire's a risk taker, team player, change agent, and innovator who is action-oriented, passionate about nursing, and demonstrates the ability to lead others in striving for excellence. Thanks for being here, Claire.
Thank you.
Dr. Catherine Ringham is an assistant professor in the School of Nursing, Thompson Rivers University, with many years of clinical practice in the field of maternal and neonatal care. Kathy teaches in both the undergraduate and graduate programs, and her current research interests are in mentorship in academia, much needed, of course. Dr. Ringham has a passion for qualitative approaches to health systems inquiry that show how people's work is organized within quality improvement, implementation, and evidence-informed discourse. Welcome, Kathy. Dr. Tracy Risling is the Associate Dean Innovation in the Faculty of Nursing at the University of Calgary, the President-elect of the Canadian Nurses Association, and the past president of the Canadian Nursing Informatics Association. With a practice background in pediatric nursing, Tracy leads a patient-oriented program of health and nursing informatics research, including, and she's going to talk about this today, research on artificial intelligence, social media, co-design, and the use of texting for wellness and workforce support. Thanks for being here.
So glad to be here.
Dr. Elizabeth Sawick is a distinguished university scholar, professor, and has been the director of the School of Nursing at the University of British Columbia, or UBC, for the past 7 years. In her nursing career, she's been both a perinatal and public health nurse, working primarily with adolescents, including homeless pregnant adolescents, 2 SLGBTQ+ youth, and sexually exploited young people. Elizabeth leads a research center focused on studying how stigma, discrimination, violence, and trauma influence young people's health, and interventions to promote health equity for youth. She has been a consultant to the World Health Organization and UNICEF, and for the Public Health Officer, Chief Public Health Officer of Canada, among many others. She was an inaugural fellow in the Canadian Academy of Nursing and has been inducted into the Sigma Theta Tau International Nursing Researcher Hall of Fame. Wow, we have quite an esteemed panel. And I'm going to be facilitating, and we will be identifying particular individuals to start our conversation and then opening the floor for everyone to just have a very organic synergistic dialogue about a few issues related to nursing education that we seem to be struggling with, and then looking toward the future. So I want to start with probably the largest elephant in the room, in my opinion. Nurses, I think, are feeling significant discrepancies, graduates, between how they see themselves as practitioners and the way the healthcare system or workplace is supporting them to practice in that way. In fact, this past month alone, I have heard from both graduates and their supporters in practice that some grads are leaving within weeks to months of entering practice, almost before they can experience transition shock. It's like they're seeing something, experiencing something that completely disconnects with what they thought they were going to be doing in nursing practice and the way that they were expecting to be treated as nurses. And it makes me wonder if they feel unprepared for what nursing practice actually is. So the question is there a growing disconnect between the current frameworks for nursing education, sort of what we are teaching, and the context of healthcare and nursing practice into which we are sending our graduates? And if so, what are those disconnects? And what programs are available or could be developed to turn the tide on those disconnects? Kathy, I think maybe we'll start with you on that.
I might be a little controversial.
Good.
Who knew? So, given my context, and as Claire and I were discussing, I come from a background of a hospital-based nursing program, training program rather than education. And at the time when I started my nursing career, in that context, I believed that a BSN was a complete waste of time and a terrible idea and didn't teach you how to be a nurse. It was just not going to be effective. I'm not sure that there's a growing gap between and disconnect. I think that disconnect has been there for a long time, and we've tried to close the gap between that practice and going out into the world as a real nurse. I sometimes wonder whether we don't introduce our first year students to enough clinical practice early on. But on the other hand, the whole purpose for a 4-year graduate program is to create a well-rounded, wholesome nurse. And by the way, I've changed my mind on the hospital-based program completely and totally. So, that being said, I wonder what we can do to support students early on without coddling. There's a lot of conversation in our department, in our School of Nursing, about whether we coddle our students too much early on, and we don't give them the harsh reality of what nursing is about. But then, if we are going to do that, then how are we preparing them for the coddling, harsh reality? They seem distant pieces, right? I went into nursing with a very romantic idea of nursing. Emily Dickinson's poem, "If I shall help one bird unto his nest again, I shall not live in vain," blah, 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 But that was where I felt in my heart of hearts, the why I went into nursing. I also knew that there was a hurry to be in clinical practice. Is that wrong? Should we be getting students earlier into clinical practice and not just having family interviews, but a little bit more intensive practice? What do we really need to teach students? Do we need to teach them about and support them in learning about their personal values and how they show up in the world, and how their personal values help their communication or help them not to communicate in an effective way? Should we be teaching them mindfulness so that they can learn how to take care of themselves? These are two things that I teach in my first year classes for students, in hopes that we will see a difference in them by the time I see them again in 4th year. So that disconnect, I'm not sure. I'm not sure if it's increasing, but it's troubling to me to know that there are more nurses that we bring through a 4-year program increasingly don't stay with nursing. And I really wonder why. I'm hoping that in this conversation today that we can start to scratch away at that and try to figure out, as a team of really intelligent people, how we can support our students a little bit better.
Thanks, Kathy. As you know, I've been in this research area for a very long time. And so I would argue that there has always been that disconnect. I don't disagree with you there, but my experience with new graduates and educators now, as opposed to even 5 years ago, 10 years ago, I've been in this for 25 years. I would certainly say that I'm seeing something different now, less tolerance perhaps for that disconnect. And they're also a different generation than 5 years ago, 10 years ago. So I just wanted to clarify that. Elizabeth.
Yeah, I would agree that there is that disconnect and challenge. Our program at UBC actually is a compressed, it's an advanced standing accelerated program. So students are in clinical the very first term, and it's a very intense one. I think there's always been a bit of a tension between the responsibility of education to present, to educate nursing students to the full scope of practice, to the ideal, to the evidence-informed, what's the best way to do things, as well as to what is the reality in the clinical setting right now, where there may be a lot of things happening because of constraints in resources, because of challenges. You know, we have just gone through a global world pandemic, and I think that's a key challenge, you know, when all of our healthcare systems are struggling in ways that we haven't seen in a while as well. So that's, you know, when you're constantly hearing about emergency departments having to be put on pause in rural areas because there's not enough beds in the regular part of the hospital to actually admit people, there is this challenge. I also think a key piece of this that I know we work on at UBC is talking about helping students recognize and address the moral distress they feel when they cannot do the thing. You know, they're rushing to manage the cares to keep people safe, and they can't do everything that they're educated to do, and that is their goal of what they are trying to provide in terms of that practice. And so, you know, that disconnect or that moral distress is a key part of this. I would say that part of maybe what we need to do is think about how we as educational institutions can continue to advocate with the healthcare settings to also improve and change. That it isn't just on how do we help our graduates, you know, get used to a challenging, impossible environment, but how do they change it and actually allow that chance to become the transformed members of the healthcare system. It's a balancing act and not an easy one for sure.
Yeah, for sure. Good points, Elizabeth. I'm thinking as you're talking about something that Kathy mentioned at the beginning, and it's not that we need to change the content about what they need to do as nurses, right? So maybe we need to talk more about what is the other content that might not be there, such as how to be resilient. And I'm not a fan of that word, by the way. Sorry. But this idea of moral distress, Elizabeth, how are we helping them to cope with the distress that they're feeling and stress in general? So yeah, good points. Is there anyone who wants to take another stab? Claire.
I'll jump in. Really good points. And I'm just gonna, because I love to go for. So totally agree. But there is that disconnect, and it's the tension that we exist, that we want them to learn it the right way first. And then how do we, though, throughout the years, help them realize where the corners can be cut and where the fundamental principles that must continue. So we get around from when the students hear people still sadly in the clinical area saying, oh, don't believe anything they teach you. They don't really know what it means to be a real nurse. So how do we work with our partners? How do we help our students acknowledge that this is the ideal? Now, how do we do that? And how do we support them in that? So one point I want to say about that too is for us, we always know we have a gap, but the people who are going into the clinical area with our students are part-time. And how do we engage with them and support them and help them understand what we're focusing on and collectively, so that they can go in as well and help, and we're working collaboratively and saying the same thing. So just that piece. But resilience, I'm going to take that one on, and I agree the word, but I was doing some research on this for something else. And it's true that the definition often is that you bounce back. And I have been guilty of putting a picture of Tigger from Winnie the Pooh, who's the tiger bouncing on his tail, saying you bounce back. But in actual fact, we may not bounce back. And how do we help our students recognize that this is a wonderful, amazing career, but it's hard at times? And what is their strategies that they can be developing? And as we're saying, mindfulness and moral distress. but how do we actually put them through exercises where it's all about their own self-awareness? Because if we say, yoga, exercise, and 8 hours sleep, none of us, and if they do, I really want to know how they do it. But so how do we get them to do exercises, identifying what stresses them? How do they cope with it? How can they better cope with it? And most importantly, who can they go for support, that they're not alone? So those are the types of areas I think that we really do need to incorporate so that we can build their inner strength, that when it is hard, rather than run, how do I deal with this? And how do I find those supports? And so that's what, so maybe we need a better word, the moral distress. Well, we need all of those words, but how do we help them with a stronger sense of the tools, the knowledge, the ability to address these difficult times?
You know, I really appreciate that, Claire, because that's exactly what I'm thinking is, how do we teach them to do something other than run? And I do think that this is a generation that has a little bit of difficulty in staying situated. This idea of moving from thing to thing because they're always being stimulated, always being stimulated. So how do we help them to calm themselves down and think of other ways to get through a situation that, as you say, this is a marathon. This is not a sprint. For those of us who've been in this career for a long time, we think about our ups and downs. I didn't cope honestly very well with some of them either, so that took time and mentorship. So we might come back to that, but I'm wondering if there's anything else just to touch this off that you think we could be doing, or maybe programs that you're aware of that we are doing in nursing education right now to help students with this. Elizabeth, do you want to start that out?
Yeah, as someone who heads a research center that 18 years ago was called the Stigma and Resilience Among Vulnerable Youth Center, and I'm another one who's like problematizing the word resilience. I actually like that we talk about resistance, not resilience, and that ability to think about, in addition to the self-care and the important things to do to create your support network, to manage those difficult days, and just the potential vicarious trauma that happens as you're working with people who have had the most extreme experiences in their lives that you are privileged to be part of supporting. There's also the skills in leadership to help our students figure out, how do you mobilize change? How do you actually work with and create that partnership with the other nurses in your unit or in your community to be able to help create circumstances that are a little more balanced, if that's possible? And for students who may not have had some of those opportunities, I'm especially mindful with the pandemic, where a lot of students did not get a chance in high school to do some of that work together of how do you actually like mobilize change? How do you create those cohesive groups? And this is an opportunity perhaps in some of our education. I know we do some of that in teaching in our program to help students really understand there are things you can do, and how can you do those in ways that are going to be effective.
Yeah, great points. Tracy.
I just wanted to highlight our nurse practitioner mental health and wellness clinic that we have running within our faculty. Tagline, as a faculty, we care for each other by building psychological health and safety among ourselves and among people we serve. And the first explanation is nursing can be a challenging program and a challenging profession. And we just recently had our academic kickoff for the upcoming year, and the wellness clinic team shared their statistics and their use statistics with, you know, a really significant increase in students and faculty and staff who are engaging. And I think it's really a wonderful support, first to normalize that you would use those kinds of supports in a tough situation, but to introduce them as a regular part of your nursing education program, in the hopes that, as you said, Judy, so well, how can we support them to draw upon resources, you know, more fight, less flight, right? And so I think that really by having these resources, you really make it a normal part. This is a tough road you chose, and we're going to teach you how to support yourself on it right from the start. And so I'm just so pleased to see that resource within our faculty, and really the uptake of it is very significant.
Oh, I love that. More fight than flight. Sounds like a nurse to me. Tracy, can you just, because I want to make sure I understand this. This is a program at the University of Calgary where nurse practitioners hold workshops and a wellness center. They run it.
Yeah, it's our own faculty members, and it's not a crisis clinic, right? It's a wellness mental health clinic, but there's all kinds of wonderful programming. They offer online opportunities, because we have a lot of students in our graduate program, for example, who are online. So they're really expanding that. But it's a wonderful, warm, inviting room. And again, there's all kinds of services there. And then, you know, what they learn from this, they bring back, not just to our faculty, but circle back into our curriculum. And so I think that by having this, you know, this get help anytime, and students can refer, and faculty members can refer, and all of us have the opportunity to drop into the clinic during those hours. But yeah, it is a wide range of really interesting supports, everything from actual counseling to meditation and, you know, biofeedback and all kinds of interesting things. And like I said, the numbers spoke for themselves, you know, as we see. And I think it's just going to become a part of doing nursing education and becoming a nurse at the University of Calgary, in that you use and draw upon these supports, and you understand, again, it's a tough job. So it's not something you do by yourself.
Oh, I like that. The two things I'm taking away are the normalization of stress, and the fact that we sometimes have difficulty coping with stress. We all do, but we can't hide that. Otherwise, it takes a lot longer and can be quite dysfunctional. And this idea, Tracy, if anyone out there has a nurse practitioner program in their educational institution, that this can actually be an educational platform for your nurse practitioner. So I mean, everybody wins. Love that. Love that. Okay, I think I might move on to similar theme in terms of attrition, but we all know that the specialty areas, and when I say specialty, I mean high acuity, emergency, critical care, high obs, those sorts of things, tend to find themselves in a bit more of a pickle when it comes to losing and hiring their staff. And there's a lot of reasons for that, but how do you think we can connect nursing education with the needs of high acuity in a way that is safe? Because putting new graduates into high acuity situations can be problematic if not done appropriately. So I'd love everyone's thoughts on that. I'm wondering, Kathy, if I could start with you.
Yeah, again, I go back to the beginning of my career, when the only thing that I wanted to do was be a NICU nurse. I didn't, and I was told, you've got to go and do med surg, you've got to go and do all these other areas. I wanted to be NICU or mat child, you know, labor and delivery and so on. And that argument and conversation has happened over all of my career, with, as I became a staff nurse, and then a clinical nurse educator, and a resource nurse in the NICU, the arguments about having students within, like in the BSN program, come and be introduced to the NICU. And I knew this was happening in all the other specialty areas as well. And whether that was appropriate, whether it's a good idea to help students to narrow their focus. My gut feeling is that if you've got somebody who has a passion for a certain area, that we shouldn't discourage it. We shouldn't be telling them, off you go and do med surg and you know, the regular kind of nursing, and come back to us later on. build your skills, because you're not going to build your skills in these specialty areas. So I find there's a lot of tension for me in that I do think that we need some place and space to build those good, solid, standard skills and competencies. But how do we then train or educate and nourish our students to want to come into safely be in ER and in NICU and critical care in a way that's going to, and again, I hesitate to use this resilient word, right? To be resilient, but to have the tools that they need, that are useful, I should say, not that they need, but that are useful in an environment where you can be, experience vicarious trauma as well as your own trauma in doing the work that is required there. I personally tell stories to my students, even in first year, about how hard some things are in nursing many times, and how I remember holding the first baby and giving that first baby that was dying to a parent, and tell them in a way that hopefully is compassionate and helps them to see that inside of a very terrible experience for you and for a parent, that you can find death in a good way, or trauma in a reasonably good way. So it's tricky, Judy. I really firmly believe in going into specialty areas. I think we need to nourish people early on, and not force them to do things that in places that they really don't feel comfortable in. I'm an advocate, but our system doesn't always allow it, right? The healthcare system doesn't always nourish or help people to be in these in specialty areas, when I think that we could do a whole lot more.
Yeah, before I turn it over to you, Elizabeth, I do want to talk about, I did research with new graduates in emergency, and it was alarming, and I published on it, so if anyone's interested. And the one thing that I recommended at the end of that particular research was that this is not an either or situation. Yes, I do think that we should be introducing students to the ideas within areas of practice that they are like, yeah, I think one day I'd like to be there, sort of thing. Do I think that we should be throwing them into situations where they don't have enough support to function at an advanced level? I saw really frightening things related to nursing practice outcomes in my research. And so I would suggest that we do need a bit of both. We do need to make sure we're introducing them through a trajectory. And I've wanted to do this research for a while. So if anyone's out there that wants to do it with me, I'm in. And that is getting the trajectories from expert nurses that have been in that area for a long time, and saying, what is it that you think needs to happen either before or during the onboarding of nurses into these high acuity areas, and we ought to be following the lead of those expert nurses. Elizabeth.
Yeah, so I was going to say, Kathy, my experience was probably just the opposite of you, and I'm recognizing that, 30 years ago when I was in nursing school, we had another series of shortages of nurses in specialty areas, which we're seeing again now. These sorts of things wax and wane. And so the alarm that I'm also hearing of nurses going early into specialty areas because there are openings. And so the healthcare system's necessarily, hiring people in, but not necessarily providing the good onboarding and the transition and supports. Like the backup isn't there. And that's a concern. When I was in nursing school, we actually had a limited group of spaces for a acute care, critical care experience in NICU. And I was one of the 6 who managed to get accepted to those 120 hours. And while I didn't end up going into NICU after I graduated, I actually moved into perinatal nursing with a lot of NICU collaboration, which again, I mean, at the time they were saying, oh, no, you should be in med surg, you should be this, but there were shortages. And so I managed to be in a labor and delivery unit and a clinic for homeless and incarcerated pregnant teens right away. So yes, it was intense, but at that time, there were really good supports and mentorship and solid backup, so that opportunity for practice and was I'm not seeing as much of that now. I think what Judy has suggested in terms of the challenges around the shortages of nurses and the demand, the large number of patient caseload creates a challenge for the system to provide the effective transition. And I know we've been doing a lot of conversations here and work within BC as a province to create these specialty pathways within the undergraduate programs to help students have more focus in the areas where they're passionate, but also with more guidance and a stronger transition pathway after graduation so that they are better supported to be in ER or in critical care or in acute complex circumstances, and now even moving into primary care as a pathway.
Yeah, in just a very quick response to that, Elizabeth, I think that there are ways to do it. It's not that I don't think that you can do it. I just think that we aren't doing it. And the other piece of this is that I don't think graduates should be hole pluggers. I don't think that that's a healthy way to nurture our profession. And I have suggested numerous times that people try to develop their staff when they're already working for them. So as a manager, I remember having no time to meet with my staff. And I'm thinking I'm managing my staff and I don't even have time to meet with them. But what I really think we need to start doing is empowering managers to sit down with their staff. I mean, I could spend, what was it, 2 hours a day, an 8-hour day, 2 hours a day at bed meetings, but I couldn't spend an hour a day with my staff asking them, where are you at right now? I think you would be a really good critical care nurse. Have you ever thought about that? And then helping them to gain the skills in my area that will help them do well in critical care, and then move them into critical care and bring the new grads into, you know, a med-surg unit or wherever you feel you ought to go. And I don't disagree, Kathy, that not every grad should go into med-surg, but funny thing, I was interviewing a new grad yesterday who said exactly that. I wish someone would have told me go into med-surg because you will get all kinds of skills you might not use as a public health nurse, but I'll tell you, if I needed to rely on my acute care assessments and skills, they were there for me. So there's a lot of differing opinions on that. Does anyone else want to speak to this high acuity? Kathy, and then Claire.
Yeah, and not a slight segue, but not really about the acuity. But what we're talking about here is mentorship, right? I'm talking about mentorship within a faculty in my current research, but I'm a firm believer in the mentorship of new grads, of all staff. And if we could bring up our leaders, I teach 4th year nursing leadership, and I hope to heaven I'm giving them some kind of foundation and some reasonable start to understand that when you communicate and develop relationships and with your team as a leader, even if you're not a manager but a leader within your team, you will have a healthier team, you will have connection, you will feel happy and content, and in those really challenging times, you will feel supported because you've got people, your people will wrap around you. So, I mean, mentorship is maybe different than the buddy system that we really want our new grads to have a system where they are supported in their clinical practice. But mentorship is also part of that. Helping them to understand that you don't want to be in this area. Well, have you thought about this? Have you thought about that? Seeing and developing relationship and communication skills with each other that will help people to thrive.
Yeah, and you know, there's they call them various things across the country. It's clinical scholars, clinical mentors. There's a few different programs out there, but what they're trying to do is provide sort of that supernumerary presence of a clinical expert who can be there for all staff, including the new grads or whoever. And I think that that's very helpful. But The one thing I'm encouraging people these days is to think about what is active mentorship, because what I'm seeing in some areas are you're with this person and you're sharing a workload, but that person doesn't necessarily understand transition, number one, for the new graduate. So they don't really know how to appropriate that support as they move forward in their transition. And 1 month to a new grad is like a year. So I think understanding what they're going through will help mentors support them. But being more involved, like not just sort of saying, come to me when you need me. I mean, we should be debriefing 3 times during that shift, and I should be there to be aware of what you're going through and what you're doing. So passive mentorship is like no mentorship at all. Is there anyone who wants to add to that topic, or shall I move on to another topic? All right. Claire, did you?
Well, no, there's so much that's been talked about, but I guess too that when you say passive mentorship, you're absolutely correct. But how do we teach our nurses about mentorship? How do we have that support? And sadly, within the economic times, we all, certainly in my experience, that the first roles that get cut are not viewed as valuable as at the point of care, are the support people. And so how do we again advocate and highlight the importance? While a nursing shortage is not good, it is a perfect time to be highlighting the need for nursing and the support of nursing. In Ontario, they have put in clinical scholars to support primarily the new grads and help them in their transition. We also have a wonderful program called the New Graduate Guarantee, which hospitals can take, although it's tricky at times, but if they do take it up, that the new grad is 3 months supernumerary. So they're not, and they're working with someone, and that they are moving on to independence and that support. But with the shortage, they want them up and running before they even get that paper done, even as our students in their final practicum. So it is this tension that we have to be working alongside our partners, and how can we be doing things in a different way?
And it's moving from short-term thinking to long-term thinking, because we've been short-term thinking forever, which is why we're in this pickle. We need to start thinking about how do we not only recruit them and throw them places we need them, but we need to say, how do we nurture them, develop them, grow them so that they'll stay with us and be the leaders of the future. So this idea that we can't, and I'm not suggesting you said that, Claire, but I do hear it a lot, we can't afford it. Well, you can't afford not to do this at this
exactly point. But how do we speak in a language with the budget people, the finance people, for them to better understand this? Like we've been saying forever, that shortage of nurses, this lower patient outcomes, larger length of stay, but we have to be continuing to push that mantra. Our students say, one student said to me, but we care, and I'm there, I'm sorry, but finance people often don't care you care. But we have to be putting it in a way that shows our value and leverage. We were heroes, but so what? A hero still doesn't get paid well, or working conditions. But how do we leverage that so that we can get those supports in there, so they don't flight, they fight?
Not to go against the grain here, but we have all of that. And we can show you in a nanosecond how much it costs you to lose a nurse versus how much it costs you to keep one. And it has nothing to do with, in this case, with outcomes. It's just plain finances. It doesn't make sense. Tracy.
Yeah, thanks. I was just going to note 2 things. One, the healthcare workforce grants that were awarded earlier in the summer. There's 15 across the country. And one of the ones we're working on here in Alberta is about holding the bookends, right? Holding these, in critical care in particular, holding the new nurses who are arriving and holding the experienced senior nurses who hold that incredible tacit knowledge. But really, Judy and Kathy, really reflecting on what you've just said about passive versus active mentorship, like a new approach, a new idea, a new exploration, I think bolder exploration of what mentoring relationships in an active way really look like. And we're just starting that work. And clearly it's something that, like, this kind of expertise is really valuable to that. And it's given me interesting insights about, you know, keeping folks like yourselves plugged into that knowledge hub that is working with these workforce grant teams. But the other thing that I've been working on is communities of practice, which I think is a term that's almost as complicated as resilience. But, you know, 10 years ago, I did my doctoral work on how, you know, generalist graduates transition in labor and delivery and the ER and oncology. And at this point right now, I'm going back to see how do the changes, the new pressures in the system, how do they influence how those communities of practice are functioning? But do we prep our new nurses to have the kind of growth mindset and the vulnerability and the bravery that's needed to really step into those communities in the right way so that they learn and the community is accepting of them? And I think that's something that we could do more of, and also really look at building, you know, a more kind of robust, supportive, better relationships within those communities of practice, because they can be quite harsh communities sometimes, but for good reason. In the research that we did, it's almost always because of patient safety. And, you know, if you are seen as a risk to that, or, you know, then you're out of the community. There's not a lot of second chances there. So I think it's about, again, it's all about the relationships. And I think there's some great opportunities for us to help all of the nursing workforce to really have a more robust foundation to step forward into the future.
Yeah, thanks, Tracy. Elizabeth, I'd like to give you an opportunity to speak for a moment about the concept that seems to be hitting the airwaves now about brave spaces, not necessarily safe spaces, because this idea of safety can be a very precarious one and cause people to be very hesitant and anxious that I'm not safe. Can you talk a little bit about how you interpret this concept of brave spaces?
So I think that one of the things that we think about, how do you both learn a new skill and a new sort of growth mindset and that ability to do things, thinking about those very first times that any of us did something in clinical. I still have like vivid memories of the very first time that I needed to give Depo-Provera injection in as the first time as a brand new nurse. And you know, it's funny because that is like mumble, you know, almost 30 years ago, and yet it's still a vivid memory. There is that importance of having a chance to take that chance to grow, to do things, and to create that opportunity does mean that there's a little stress involved, but I think of it as that supportive stress, that laddered stress. You do things that are a little bit stressful and you can achieve them, and that gives you confidence that you can handle that moment. And, you know, the first time you are part of a code, then, you know, it's intense, but then you have that recognition that this is something you can do. So during education, part of that work of our educators is thinking about how do we set it up so that there is an opportunity for students to take that risk, to stretch themselves, to feel challenged without being, without feeling overwhelmed or without feeling belittled. So that chance of saying brave spaces, or that chance of being able to do that practicing. And I know in our program at UBC, there are early on those opportunities to do that where there aren't necessarily stakes involved around marks. Simulation with feedback that doesn't necessarily have a grade attached to it. And then that ratchets up. But there is that encouragement of this is important spaces for us to be able to speak some of those difficult things, to be able to have that opportunity to process, but also to be able to step up and try something new. that's I think what I would think about in terms of thinking about brave spaces. This is not to say when we think about safe spaces, we're also dealing with and addressing the issues of the lateral violence, the horizontal violence that happens in nursing, where we've often heard we eat our young. That ability of sometimes that emphasis on patient safety also can be used to give a pass to disrespectful behavior or unhelpful behavior or even bullying and harmful behavior. So part of it is also we have in our program conversations about how do people interact and engage and address issues of bullying and that potential of that the challenging environments, while also encouraging people to be willing to step forward and work on and try those difficult things and be brave, as you say, but in circumstances where there's a bit of safety around that managed stress or that managed risk, to build that skill and that confidence.
Okay, thank you, Claire. That was a good cue. It comes to mind for me, this idea of preparing them in situations for stress when the outcomes aren't like potentially tragic. And that I'm talking about patient outcomes, right? First of all, Tracy, you talked about how do we prepare people to mentor? How do we prepare people to give feedback in a healthy way? I mean, when was the last time an in-service was given on that? But this idea of SIM where they can be taken beyond the edge, like they can actually fail in SIM and then you go back, and cognitive rehearsal therapy is a perfect example. Let them do whatever they were going to do and then back them up and start again. That's adult learning principles. So how are we implementing those in undergraduate education, and certainly how are we facilitating that as nurses move through their practice? Is there anyone else who wants to comment on brave spaces? Well, then I want to talk. Oh, is someone wanting to?
I just wanted to add, sorry, I was the one muted this time, that we have to help our students again with this whole building their inner strength and courage and being brave is being comfortable with being uncomfortable. And how do we do that? How do we do that in practice? As you say, with SIM, it's a beautiful place where sadly the person can die and they don't really die. So and to work through that, because in all our students, I think the thing they're most terrified of is somebody coding on them. So how do we help them with that and learn from it? So that's one way, but also in our conversations. And so safe is where you're comfortable, but being uncomfortable is where there is discourse, but it's done in a respectful way and a civil way, and being able to learn how you're reacting. And so oftentimes when I'm thinking, oh, I'm feeling uncomfortable and I don't like this, I'm not really hearing what Judy is saying. So to give them those skills too, and it is, I'm so thrilled that we're talking about all of these more emotional intelligence and psychological skills to build them up to be the best nurse that they can be.
I love that comparison, Claire. Safe and brave. Safe is where you're comfortable, and it's, you know, that's got its place. But brave is where you're uncomfortable, but you're still safe. Uncomfortable, but you're willing to move forward anyway.
Right. And that raises right into, how do I speak with the physician or the other care provider, and helping them work that through simulation within the classrooms. It takes sometimes, if you're having a very difficult conversation in a classroom, the instructor has to be brave instead of saying, oh, I don't want to go here. And so how does one do that, setting norms of how we're going to again, another knowledge skill to be developed throughout their education.
Yeah, and that kind of segues nicely into a discussion on our advanced digital technologies in the healthcare field? Because how can they, where technology is everywhere, how can we use it to create these kinds of learning opportunities and contexts as real as we can make them for students? And Tracy, I know you're doing a lot of work in this area. I'd really like you to start our dialogue about that.
Sure, absolutely. Well, I really, building off what Claire has said, I think, simulation has always been such a fascinating place with so much possibility. And now, of course, with virtual reality and augmented reality, and then mixed reality and things like virtual simulation, the VR, we've done some research on VR and educating patients who are on dialysis, and it is incredible. And actually their nurse is with them in the virtual world. And, it really, really is incredible. And I think, again, it's about making it realistic to lessen the shock, right, between that educational kind of setting and the real world. And I think that there are technologies that are doing an incredible job of bridging those worlds, right? Beyond gaming, right? Beyond zombies, right? Like if I can feel actually that I am about to perish in the hands of a zombie, certainly we can adopt that technology to give nursing students a very real, authentic experience that they may encounter, and to help them to practice those skills in a way that when they do actually encounter it, they don't feel the flight, right? They are ready to employ all of their tools to stay in that situation and to minimize the impact themselves. And I think the other thing, so on the education piece, is, are we preparing nurses for this digitally enhanced future? Are we actually educating undergraduate nurses who may never interact with a patient in real life, who will only always deliver virtual care? Because that is a lot closer. Those opportunities for nurses to practice that way for the entirety of their career already exist. Now, talk about a paradigm shift. Did we really think about what nursing looks like when it is entirely delivered through a virtual platform? Remote patient monitoring, wearables, the data, all of the advanced charting technologies in hospitals, and we do a great job with that. And then, of course, there's the whole introduction of artificial intelligence and machine learning, and things like natural language processing and programming, which is so really, it's a game changer for the representation of nursing and nursing data, really in this digital sphere and in this digital space. But if we take it back to foundations, I don't think that we should teach every undergraduate nurse to code in Python, right? Because first of all, the AI will be doing that by the time these undergraduate nurses who are doing their orientation next week, by the time they leave. This is the thing, though. By the time the nurses we will welcome in the weeks ahead in orientation leave in 4 years, the digital transformation of their practice landscape will be significant. So let us lay down the same kinds of foundations we're talking about data literacy, about critical thought, about understanding the basic foundations of where digital practice intersects with nursing practice, the care, the art of nursing, and how that all comes together to be the nurse of the future.
That's great. Tracy, thank you for your expertise in that. I did an interview with Bonnie Clipper, and Bonnie runs the Academy of Virtual Nursing in the US, but she's an international scholar. So certainly connecting with Tracy, looking at Bonnie's work, I think would help people to start to think about, how do we do that? So Elizabeth, you're a dean. How do you do that? How are you doing that?
So this is such an important point, because the technology is constantly evolving, and there are so many changes. There are things that we learned how to do that in nursing school that are irrelevant now. I'm not even sure we're teaching students how to count drips and IVs, because the IV pumps are already doing that. But one of the things that we've seen, certainly over the decades of improving technology that is still salient is that tendency for our as humans to either ignore the tech or to over rely on the tech. The look at the tech, forget the patient in the room, or ignore the tech because it's not working often enough and miss, what's really happening with the patient, and therefore lose some important opportunities before something bad happens around their health and well-being. So I think that it's really important for us as educators to ensure that students are exposed to and are working with the current tech and aware of the future tech and the things that are changing as rapidly as they are. This is tough, especially for those of us who have a hard time keeping up with what is the latest, particular equipment that's going on. But we do have in our program informatics as part of, not coding in Python, definitely not, but thinking about how we communicate and how systems are communicating, how we learn about the, electric medical records and the other kinds of technology. And I do think that we're still recognizing how AI and the large language models and the machine learning and other things are going to be influencing our practice. The one important concern that I think we need to be continuously mindful with our students and helping them maybe be those folks who are excited about, but also challenging where we are with that with AI involvement, is recognizing that we're still in a place where that AI learning is creating mistakes, and being able to be cautious and say, yes, we need to make sure that this is, moving in the right direction, but are we there yet? For certain kinds of AI. I mean, we've all seen the conversations around ChatGPT and how students are doing their papers, and oh gosh, they're making up citations. And that's a concern. But a bigger concern is when AI draws on the limited knowledge it has and hallucinates a solution that is actually wrong and is going to cause harm to patients. So I think there's a lot of work to still be working on that. In fact, we've got one of our faculty who is developing an AI-driven clinical judgment interview skill set for our nurse practitioners, but also will be for our nurses. And it's fascinating because the computer colleagues who are doing that work are really, excited about it. And our faculty member, Ash, he is like, yes, this is great, but it's got to be accurate. It has to nope, sorry, they've missed the diagnosis. They've sent the conversation in the wrong direction. And now the nurse has missed it. And this patient is going to die. Not okay. So that ability to be, I mean, it's so important for nurses to be part of that tech, to ensure that the expertise is there, to make sure that the engineers and computer programmers actually have the knowledge to be able to provide really effective tech.
Yeah, and Tracy, before I go to you and then Claire, I think we are in a major transition, right? And transition is a process and it takes time. So we are certainly not where we need to be. And it in that in-between place, Elizabeth, that the danger lies, right? Because and opportunity, sure, but the danger that we haven't infused that AI with enough nuanced knowledge. And the challenge with with nursing is that usually it's all about the nuances. Tracy.
Thanks. I'm going to make 2 quick points and then otherwise I'll be stuck in this conversation forever. But first, what I want is for us to prepare all nurses to feel like they have an important voice in any technological discussion they encounter. So that same confidence that we're talking about them, making a thoughtful transition into critical care, I'm talking about a need to move nurses from advocacy to activism in the advancement of all digital technologies in spaces across all areas of practice. We can't just be advocates anymore. We need to, and again, they don't need to know how to make machine learning function. They need to know that machine learning has a social justice and equity problem, and that the data that's being used has a problem, and that in order for it to really right some of the wrongs that still exist in our healthcare systems, it has to be done in a different way. All of that nursing expertise exists. And I'll just close my points on this by going back to some work by Bernard and Sandalowski from 2000 that I'm revisiting right now in a 25th kind of anniversary reflection, where they talked about nurses depicting ourselves as the bridge spanning the divide between technology and humane healthcare. And this is the quote: that we have thereby claimed professional ownership of the space between technology and patient. We have always held this space, and we must continue to do so to make it safe and to make it right for everyone that we serve, not just for our patients, but for ourselves. And that is the way we're going to move forward into a better digital future. I truly believe that.
Oh, thanks for your passion and knowledge about this area, Tracy. Claire.
Wow, I don't know if I should just be quiet and leave it at that, but it's hard for me to be quiet. But I absolutely echo you, Tracy, that we have to be teaching our students an understanding of what this means and what it'll be. And most importantly, as you were speaking, Elizabeth, I just wanted to jump in, and I restrained myself in the sense of, but that's why we need humans. That's why we need nurses, is to be there at the bridge to question, is this correct data? Is the data they're using unbiased? Is it right? And that questioning and informing, because we know it's a huge business. 35 billion or something is being spent on all of this. And we have to be informing what is safe and ethical and questioning. And I love moving from advocacy to activism, but they have to have the knowledge and the ability to do that. So we do have to be teaching them that, so that too, that they are using their critical thinking, their clinical judgment, assessing what is being done, ensuring that equity and ethics are being maintained to be able to move to the future, because it's moving. And we need to move with it, not only with it, but leading it in any way we can. And that means we have to be giving the students the knowledge and skills to do that. It's a shame. It's a shame that this group isn't passionate, really. Yeah.
Well, I think that's a great way to begin our wrap up. And I'd like to give everyone an opportunity to sort of give a synopsis of what they think we need to do to move ourselves in a professional, advanced, and healthy way forward in nursing education. Kathy, I'd like to start with you.
Wow, thank you. It's a real honor and a privilege to be amongst such greatness here on this panel. I really feel honored to be able to share all of these ideas, and Tracy particularly in an area, simulation and technology that is so far away from the beginnings of my clinical practice, where as Elizabeth said, we were counting drops, trying to make sure that we got the right amount of fluid into our little babies. I'm going to just take this to quite a personal and in my present situation. I'm probably in the twilight of my career. I have come back to academia to teach, and I'm talk about this bookending piece, bookending first year communication collaboration with fourth year leadership, nursing leadership, and then seeing some of final CPE students in clinical practice. So from my perspective, all of you have talked about the things that I see as so incredibly important about developing relationship, developing understanding of self, developing that sense of being comfortable, supporting students to understand that it's okay to be uncomfortable, to lean into that discomfort in a way that you can see opportunity for learning and not failure, but learning that you can recede back to that safe zone and take that learning to help with your foundation of how you're going to be a nurse and show up in nursing. So I feel so inspired about how I'm going to do the next few weeks with my communication collaboration students. I am so incredibly excited. And then to be able to teach my nursing leadership class even after that class through the fall, to be able to support them in how do you show up as a leader? How do you identify as a leader? How do you see your role as novice leaders in your practice, as even as new grads? How can you recognize how to build communities of practice even as new graduates, and take that inspiration and that sense of this is important to me as a nurse, to develop communities of practice, to develop relationships with people and understanding about how we do nursing, how we are at the bridge and how we provide that bridge, you know? So that for me, I feel so incredibly inspired that I can take some of these things that we've talked about and amplify them even more in this bookended courses that I'm teaching this fall. And I'm only one person, but one drop in the water creates an awful lot of ripples. And that would be my hope, that the ripples will move out and make a bit of an impact on, if not just one person, maybe a few people, and maybe a lot of people.
Thanks, Kathy. We do need to start with ourselves for sure. And coming in with the mindset of what we want to see in the future is what will come out of our practice as educators. Elizabeth, I'd like you to go next if you don't mind.
Sure. There's been so many things that we've talked about that resonate. There's just like so much. It's hard to sort of land down. I do think one of the things I would like to say is that with the rapid changes in technology, the things that are going on in the wider world, the intense pressures within our healthcare system, I don't want to lose sight of, as much as our students are potentially stressed and challenged by this, they also have some of those digital skills as folks who have been exposed to and working with it, including, those games where they're being chased by the zombies, the skill sets and knowledge to be able to be comfortable with tech in ways that perhaps some earlier generations had not been. So as much as we continue to need to encourage and to create those effective strategies to help people with their transition to practice, and that we need to be thoughtful about how are we both providing the evidence-informed and aspirational care, the full scope of practice of what nursing should be, in addition to, and here's the reality of what it is in the world, and oh yes, here's some skills for how you can transform it to what it should be. I think we also need to remember to keep giving our students credit for the knowledge and skills they already bring in navigating a crazy world right now. And that they will have those ideas and that capacity as long as we continue to ensure those opportunities for them to have brave learning opportunities in those brave spaces, and that ability to create their community circle of support so that they can stay with it instead of, what was it? More fight, less flight. Thanks.
That's definitely been a theme for us, hasn't it? A lot of themes have come out of this, Elizabeth. Thank you so much. Claire.
All right, so much has been said. So, and it has been truly an honor and privilege to be with you all, and as well as to learn and find your enthusiasm. I think what we've talked about so much, and what I think is important, is to look to the possibilities, the opportunities, and the strength. Us in leadership positions, it's so easy to get bogged down with what all the things that are happening that are wrong, that one loses sight in all the possibilities and opportunities. So to support one another in identifying that, and to be looking and highlighting to ourselves, like as you said, Kathy, you don't just influence one person. And even if you did, they're going to influence with their ripples, so that we do have this tremendous opportunity and ability to carve out, even with that one person, the future that we have in nursing and where will that go. So thank you so much. And I look forward to working with you all at some point later.
You know, the other thing I've been hearing a lot of is that, particularly, and we're ending with Tracy, the digital technology and the way it can help us. The fact that a lot of faculty, and this is an assumption, but a fair one, I think, are not as versed in a lot of this technology as our students are. So immediately that puts faculty in an uncomfortable position where they might feel like they're not leading, right? And how do I exist with these students and be able to have more of a mutual narrative going on around learning? So Tracy, I'd like to leave you with the final word, if you will.
The perfect opportunity for brave spaces, Judy. You know, there has to be a humility there, and it's okay. It is okay to feel unsure about technology. But you know, you cannot deny technology. And I think, you know, the other thing that I want to recognize is that even among the faculty who maybe feel like, you know, their digital skills aren't at the height of where technology is today, all nurses are innovators, are problem solvers. I have never had the privilege of being in such a profession, no matter what area of practice, where the second a problem hits the ground, 3 nurses are like, okay, here's 5 ways we could solve this. Because that's just how nursing is. That's why, and we're doing some work with the Canadian Nurses Association and Ciel, which is a nurse innovator organization, to really amplify and recognize the power of nursing innovation here in Canada and around the world. And so that's where I want to close. I actually want to firmly put my president-elect CNA hat on now and remind everyone, faculty, nursing students, new nurses, long-standing nurses, about the importance of connectivity and collaboration and the power of our unified voice. And we're seeing a lot of drop off in association membership. But there is an association for every kind of nursing. Just yesterday, I had the privilege of sitting in the Canadian Network Nursing Specialty meeting. And no matter what kind of nursing you're passionate about, there's an association for you. And I think we need to encourage our students to make those connections, to maintain those connections when they land in practice, to realize that having a membership in the CNA connects you to the International Council of Nurses, the global voice of nursing, and it helps us to do things like, you know, engage with our politicians at the highest levels to really try to change opportunities, supports, and the future of nursing. But no nurse can do it alone, but no nurse is ever alone. And I think that by promoting association engagement and development, we will find that all of us feel like that fight is easier for the future.
Well, now we know why we wanted you as our president-elect, Tracy, and you and Val will do such an incredible job over the coming months and years. So thank you so much for that. I can't really summarize or recap. There's absolutely no need. The scholars on this panel have done exactly that. So I just want to thank you all. I can't wait to get this video available to all of our colleagues across the country. And thank you so much again for your wonderful work.